Now, hepatic encephalopathy is a syndrome of disordered consciousness and neuromuscular abnormalities resulting from the buildup of neurotoxic substances in the bloodstream, such as the ammonia, which affect the brain function. And hepatic encephalopathy commonly affects patients with chronic liver disease, but sometimes it may develop in patients without prior liver conditions who develop acute liver failure, and that is because the liver function is to detoxify the blood coming from the intestine, and once the liver is ill, the toxins pass into the systemic circulation because the liver cannot detoxify them anymore, leading to hepatic encephalopathy. Now, as you can see in this picture here, all the blood that is coming from the intestine will collect in the inferior mesenteric vein here and the superior mesenteric vein here and into the portal vein here and into the liver. So the liver works to detoxify all of this blood and send it to the systemic circulation via the hepatic vein and into the inferior vena cava. And once the liver is impaired, the blood that is coming from the intestine with all the toxins inside of it will not be detoxified, and that means toxins would reach into the systemic circulation and into the brain, causing hepatic encephalopathy. Now, the hepatic encephalopathy is caused by chronic liver disease or acute fulminant liver failure. So in these conditions, the liver cannot detoxify toxins coming from the intestine into the systemic circulation, and this would lead to the toxins reaching the brain, and this would lead to hepatic encephalopathy. Now, it is also caused by the redirection of blood flow away from the liver in portosystemic shunting, for example, in the transjugular intrahepatic portosystemic shunt or in spontaneous shunts. So, in this case, the blood does not go in its normal path of going through the inferior mesenteric vein and the superior mesenteric vein into the portal vein and into the liver, but it goes through a different way. So instead, the blood will be shunted from the portal vein and directly into the systemic circulation through one way or another. And by this mechanism, the liver will be bypassed and it cannot detoxify toxins anymore. So the toxins are bypassing the liver into the systemic circulation, and the toxins are reaching the brain, and this would lead to hepatic encephalopathy. And hepatic encephalopathy occur in up to 50% of patients undergone transjugular intrahepatic portosystemic shunting procedure. Now, hepatic encephalopathy is also caused by spontaneous portosystemic shunts, and those occur when the fetal shunt pathways between the portal and systemic circulation open due to high blood pressure inside the portal vein in diseases such as liver cirrhosis. Eventually, the systemic shunt increases in volume and the portal circulation declines. Now, in chronic liver diseases such as liver cirrhosis, the liver would undergo fibrosis, and this would lead to the resistance to the blood being high inside the liver. And since we have high resistance inside the liver, we will have higher pressure inside the portal vein in order to get the blood into the liver and out of the liver. So high pressure in the portal vein would lead to the opening of the spontaneous portosystemic shunts, such as the gastric portosystemic shunts, the gastrorenal portosystemic shunts, and the gastrocaval portosystemic shunts. And all of those bypass the liver into the systemic circulation. Now let's talk about the pathophysiology of the hepatic encephalopathy. So normally, the intestinal bacteria and the digestive enzymes break down the dietary proteins, releasing the ammonia within the gastrointestinal tract, and the produced ammonia get absorbed into the venous circulation to the portal vein and into the liver. Now, in the normal liver, the ammonia is converted to urea via the urea cycle and excreted through the kidneys. Now, in cases of liver failure or systemic shunts, the ammonia can accumulate and get diverted to the systemic circulation, leading to hyperammonemia. And the ammonia is a neurotoxic substance, and it can cross the blood-brain barrier. And when it crosses the blood-brain barrier, it reaches the brain, where it impairs the excitatory neurotransmission, leading to disruption of neuronal function and encephalopathy. Now also the ammonia will be converted to glutamine in the brain, which act as osmolyte, causing increase in cerebral volume and brain edema. Now, risk of cerebral edema is really high when the arterial ammonia levels surpasses the 200 micromole per liter, and those levels are reached in fulminant acute liver failure more than chronic liver failure. Now, if hepatic encephalopathy occurs in patients with chronic liver disease, then it is potentially reversible and treatable, while if it occurs in patients with acute liver failure, then this leads to rapid increase in blood ammonia levels, which is difficult to control and result in widespread brain edema and structural brain injuries, and those might be irreversible. Now let's talk about the clinical features. So hepatic encephalopathy is characterized by appearance of neurocognitive and neuromuscular manifestations. So for the neurocognitive manifestations, those include reduced awareness of one's surrounding and stimuli, and it is accompanied by behaviors such as yawning and sleeping for short periods of times, and patients may also develop insomnia or hypersomnia. And as the condition progresses, the patient develop increased levels of confusion, lethargy, and personality changes. Now, the neurocognitive manifestations mentioned already are variable and precede the neuromuscular manifestations. Now, neuromuscular manifestations, on the other hand, they include bradykinesia, which is slowing of movement, asterexis, which is a flapping tremor, and slurred speech, ataxia, which is impairment in coordination, and hyperactive deep tendon reflexes, and nystagmus, which is abnormal eye movement. In later stages, the patient may experience jactitation, which is a twitching of a limb or a muscle, and positive Babinski sign. Now, less frequently, the patient may develop areflexia, transient, decerebrate, posturing, and coma. Now, some patients may develop focal neurological deficit despite negative CT or MRI brain scan. Now, if hepatic encephalopathy developed in patients with chronic liver disease, then other clinical features related to chronic liver disease might be present, such as muscle wasting, jaundice, which is yellowish discoloration of the skin and the mucous membranes, and ascites, which is fluid collecting in the peritoneum, palmar erythema, and edema, and spider telangiectasias, and fetor hepaticus, which is abnormal smell. But if hepatic encephalopathy developed in patient with acute fulminant liver failure without a history of chronic liver disease, then some of those findings, such as muscle wasting, spider telangiectasias, and palmar erythema, are absent. Now let's talk about the diagnosis. So to diagnose hepatic encephalopathy, liver disease should be confirmed through liver function tests, radiologic imaging, or liver biopsy. And there should be clinical features of hepatic encephalopathy present. Now, it is also important to exclude etiologies that mimic hepatic encephalopathy, including intracranial lesions, stroke, post-seizure encephalopathy, central nervous system infections, or toxic encephalopathy from other toxins such as lead and pesticides. Now, regarding the blood ammonia level, so the elevated ammonia levels in arterial or venous blood is not sufficient for diagnosing hepatic encephalopathy, and it is not used in the diagnosis because ammonia levels are variable and they don't reflect the clinical features of the patient. So the clinical features are more important in the diagnosis. And the reason behind the ammonia level variability is because the brain might already absorbed a lot of ammonia when the test is done. So the ammonia would be low or normal when you take the test, but in fact the brain already absorbed all of that ammonia, and this leads to hepatic encephalopathy despite low blood level ammonia. Now, regarding the liver function tests, so those are abnormal due to the acute or chronic liver disease, and they manifest as elevated bilirubin, elevated alanine aminotransferase, and aspartate aminotransferase, and they also may manifest as elevated international normalized ratio, and that is because the liver is responsible for synthesizing the clotting factors, and once the clotting factors are low because of the liver is unable to synthesize them, this would lead to elevated international normalized ratio. And this also may manifest as decreased albumin because the liver is also responsible for synthesizing the albumin. And once the albumin is low, this means that there is a problem in the liver. Now we also have the electrolyte disturbances. Example for those is the hyponatremia or the hypokalemia. And those disturbances are due to the hepatic dysfunction or the use of the diuretics. Now we also can order an electroencephalogram for the patient, and this would show an abnormal findings, but those are not specific for hepatic encephalopathy. Now we also have the imaging tests such as the CT or MRI scans, and those are utilized to exclude differential diagnoses such as intracranial lesions, stroke, or hemorrhage, and the CT scan may show generalized or localized cerebral edema in hepatic encephalopathy, and the MRI is superior in showing the cerebral edema more than the CT. Now let's talk about the treatment. So the treatment include supportive therapy and ammonia lowering therapy. The supportive therapy include supporting nutrition, avoiding dehydration, avoiding electrolyte abnormalities, and providing safe environment and preventing accidents and falls. The ammonia lowering therapy, on the other hand, include the use of medications such as lactulose or lactitol and the rifaximin. Now, initiating the ammonia lowering therapy is based on the clinical signs of hepatic encephalopathy, and it is not related to ammonia levels because the ammonia levels are not elevated all the time in hepatic encephalopathy patients, as we mentioned earlier. So once the patient develops the clinical signs of hepatic encephalopathy and they have the diagnosis of the hepatic encephalopathy, then we start the ammonia lowering therapy. Now let's explain the supportive therapy for hepatic encephalopathy a little bit more. So we mentioned that we have to support the nutrition of this patient. And when we support the nutrition, we recommend that the proteins should not be restricted for these patients, and it should be maintained at around 1.2 to 1.5 grams per kilogram per day. Now, previously, the proteins were restricted for these patients, but recent studies showed that restricting proteins would accelerate the hepatic encephalopathy in these patients. So the proteins should not be restricted for hepatic encephalopathy patients. Now, the logic for protein restriction that is done in the past is that the proteins will be converted to ammonia inside the gut and will be absorbed and will aggravate the hepatic encephalopathy. So restricting proteins will mean that there is less ammonia produced and less hepatic encephalopathy. But recent studies have concluded that proteins should not be restricted, and the logic behind that is the hepatic encephalopathy patient is malnourished, so they need different types of nutrients, especially proteins, to keep their body strong and able to fight the hepatic encephalopathy. So restricting proteins will mean further exacerbation in hepatic encephalopathy because the body will be much weaker. Now, the caloric intake for these patients should be around 35 to 40 kilocalorie per kilogram per day. And it is highly advised for these patients to consume small meals throughout the day and to prevent fasting because fasting leads to increased ammonia production and further exacerbation of the hepatic encephalopathy. Now, it is also important to provide a safe environment for these patients because hepatic encephalopathy patients may be agitated and pose risk to themselves and to caregivers. And it is crucial not to use sedative medications such as the benzodiazepines in treatment of agitation because they exacerbate the encephalopathy. And in treatment of hepatic encephalopathy, it is very important to understand the hepatic encephalopathy triggers in chronic liver disease patients because these triggers have to be avoided or treated. And those triggers include renal failure. Now, renal failure may trigger hepatic encephalopathy because in renal failure, there will be accumulation of urea because it can't be excreted through the kidneys because they failed. And once we have higher amount of urea, we have more nitrogen inside the body, and we also have more ammonia inside the body. And this means that we have higher risk of developing encephalopathy. The other trigger for hepatic encephalopathy is gastrointestinal bleeding, for example, from esophageal varices, because in gastrointestinal bleeding, the blood would go through the intestine, and through its course through the intestine, the nitrogen and the proteins inside the blood would be converted to ammonia and absorbed in high levels into the systemic circulation, leading to triggering the encephalopathy. Now, the other trigger is constipation, because constipation accelerates ammonia production, and also we have infections such as spontaneous bacterial peritonitis or urinary tract infections, and hepatic encephalopathy may be triggered if the patient is non-compliant to medications. Now, hepatic encephalopathy may also be triggered from excessive dietary protein intake, and we already talked about protein intake. It should be maintained at 1.2 to 1.5 gram per kilogram per day, and it should not be more than that. Now, also dehydration might trigger hepatic encephalopathy, and that is because factors like fluid restriction, diuretics, diarrhea, vomiting, or excessive paracentesis for the ascites, all of those would lead to dehydration, and dehydration would impair the kidney function in excreting the urea and would exacerbate the ammonia levels. Hepatic encephalopathy may also be triggered from electrolyte imbalances such as hypokalemia or hypoglycemia, and it also can be triggered from the alcohol consumption, because alcohol heavily influences the liver condition, and it may be triggered from the use of sedatives or analgesics, because those medications may accumulate and cannot be excreted and would also aid in the development of encephalopathy. Now, the other part of hepatic encephalopathy treatment is the use of the ammonia-lowering medications, and those include the lactulose. So the lactulose break down in the gastrointestinal tract, leading to acidic pH inside the intestine. And remember, the pH inside the intestine is alkaline, so when we use the lactulose, it becomes acidic, which facilitate the conversion of ammonia, the NH3, into the ammonium, which is the NH4+. And the ammonium, which is the NH4+, would not diffuse to the bloodstream as much as the ammonia diffuses due to it being charged. And remember, charged molecules have problems crossing membranes, and the ammonium also can't cross the blood-brain barrier for the same reason, because it is charged, and this would lead to lower levels of ammonia reaching the brain. So by this mechanism, lactulose works to lower the blood ammonia. Now we also have the rifaximin, and this is an antibiotic that is poorly absorbed from the gastrointestinal tract. So it works locally on the gastrointestinal tract to eliminate the bacteria that produce the ammonia inside the gastrointestinal tract. And this would lead to lower amount of ammonia because we have less bacteria producing the ammonia. And this medication is considered for patients not responding to lactulose. Now, the definitive treatment for hepatic encephalopathy in chronic liver disease patients is liver transplantation. Now, finally, let's talk about the complications. So, complications of hepatic encephalopathy include seizures, and residual cognitive impairment in patients who have clinical improvement, and also in acute fulminant liver failure. The complications might include cerebral edema, seizures, and brain herniation. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe.